Okay, it's 1:45. Good afternoon, everyone. My name is Sharon Powell, and I am the administrative assistant here at First 5 Kern, and I want to welcome you to the Healthcare Bias in Black Infant and Maternal Health. Before we get started, I wanted to review a couple of housekeeping rules. The chat feature will be used today to ask questions. Only the presenters and I will be able to view the chat. I will be providing your questions to the presenters throughout the workshop. So please type them in and as they come up. Ms. Lester, do you have any additional housekeeping rules or questions, or Ms. Rutledge? Either one?
No.
Thank you. Moving on. Okay, so today's presentation will highlight the healthcare bias and how it affects health outcomes in Black infants and mothers. In addition, we will share data regarding infant and maternal deaths in our local Black population and the local efforts currently underway to improve health outcomes in our Black infants and mothers. The discussion will feature remarks from Amy Rutledge, and the session will focus on principles for community-centered practices that serve as vehicles for innovation in health equity and community service delivery. Today's presenters will be, as I said, Amy Rutledge, Assistant Director of Public Health, Kern County Department of Public Health, and Ms. Anastasia Lester, Program Officer here with First 5 Kern. Ms. Rutledge graduated.
Baby.
Can I have everyone mute their mics? Thank you. Ms. Rutledge graduated from Cal State Bakersfield in 2006 with a bachelor's degree in biology. The same year, she started working for Kern County Environmental Health as an environmental health specialist in training. After earning her registered environmental health specialist certification, she went on to become a supervisor, division chief, and eventually director of the environmental health division in 2020. Ms. Lester, Aname, as I affectionately call her, has worked in the public sector for more than 20 years. Anastasia has trained nearly 100 organizations on how to provide strategic planning and parenting to their local communities. Anastasia received her master's degree from National University in Special Education, Human Development, Public Administration, with an emphasis on organizational leadership. I now turn the mic over to you, Ms. Rutledge. Thank you.
Good afternoon, everyone. Just wanted to say thank you for joining us for this session. I know there were a number to choose from. So we hope that you take away from this something that you can implement in your everyday profession and that helps you grow. Before we get into the presentation, I'd like to ask Anna to put up our first poll for today. We'll give it just another few seconds to see who we have in the audience. And it looks like we have a good mixture today. So we have some government organizations, as well as those representing our medical field, academia, local CBOs in our community, as well as those who've chosen the other category. So it's great to have a nice mixture here today. Next slide, please. So the chart that you see here is maternal disparities by age. And we have this here because we'd like to start by giving you some background information on the maternal health. In this chart, we have pregnancy-related deaths by race and age. And as you can see, inequities increased by age, with the disparity for Black women older than 30 being 4 to 5 times that of their white counterparts. Next slide, please. For this chart, I would like to first point out that we will be looking at them separately, but keep in mind that the green bar on here is the data for our Black population. So this is California specific data. As we look at this, I'd like to first talk about preterm and low birth rate because they usually go hand in hand with one another. And for those of you who don't know, preterm birth is defined by the CDC as when a baby is born before 37 weeks of pregnancy. And low birth weight per the CDC is defined as a birth weight of less than 2,500 grams. I know we're used to things in pounds and ounces, so that's 5 pounds, 8 ounces. As you can see from the chart, a higher number of Black infants are born preterm or underweight when compared to all other races. Research shows that being born early or small means infants may suffer from underdeveloped organs, breathing problems, be more at risk of infections, and have other serious ailments that may affect their health overall. As we move to the two bottom charts, we have infant mortality, which is defined as death of an infant before the age of 1. Here, I would like you to note that Black infants are dying at a rate of 2 times the rate of every race except American Indians and Alaskan Natives. Lastly, we're going to look at maternal mortality, which is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy. Black women are shown on this chart to be dying at 4 to 5 times the rate of any other race. And research shows that Black women continue to experience significantly higher rates of maternal related deaths, even when they are pregnant at an optimal age, have a high income, or are well educated. In addition, the US has one of the highest maternal mortality rates when compared to other high income industrialized countries. Next slide, please. Here, I'd like to take a moment to point out that while short gestation period, which is preterm birth, and low birth weight are the #2 leading cause of infant deaths in the US, it is the #1 cause of death for Black infants. And as you can see from the data presented here, it is disproportionately out of line with their white counterparts. Next slide, please. As we get into more Kern County specific data, in this, you'll see a state to county comparison where the infant mortality rate for Kern is above the statewide average for each year over the last 2 decades. And while we are continuing to see a decline at both the state and county level, Kern County infants continue to be disproportionately affected overall. Anna, I'd ask that you send up our second poll, please. Give it just another moment. So it looks like we had a pretty even split on those statistics. I notice a few names that we know, so I know that you're part of some work that we're doing, but it's great that we're able to get this information out into the community so that we can help you understand what it looks like here in Kern. Next slide, please. So now that we've talked about our data and what it looks like, we'd like to talk about what we're all here for. So what is bias? We have 2 forms of bias that generally exist. You have the implicit or the subconscious, and the explicit or conscious. Everyone is aware of what explicit bias looks like, as it is often the type that is in your face, but implicit bias can be harder to decipher. Oftentimes, people may self-identify as unbiased and not recognize that they are implicitly biased. And that is because implicit bias often manifests in the small, unconscious responses to a situation, such as passing quick judgment on someone's abilities due to their age or physical appearance, or assuming one's socioeconomic status based on their race. Next slide, please. So what bias exists in healthcare? So here you'll see a few different ones: sexual identity, geographic location, socioeconomic status, age, obesity, sex, gender, racial bias, and ableism. And in here, We would like to include a link for you on how you can test your implicit bias. I'm going to drop that into the chat. And at this time, I will also ask Anna to put up our third poll. Give it just another moment. All right, so it looks like we have a good understanding of what implicit bias is, and we're going to keep that in mind as we continue on with our presentation. Next slide, please. So biases affecting Black infant and maternal health outcomes. The three that we see most often are race and ethnicity, gender, and socioeconomic status. While race and ethnicity, as we saw before, can be two separate categories, they are often looked at together, and this is discrimination based on your skin color or your country of origin. Gender oftentimes can be interchanged with one's sex, but it's discrimination based on a person on their sex or perceived gender, and socioeconomic status is discrimination based upon your economic means. Oftentimes, a person who falls within two or more of these biased categories has an additive effect on implicit bias that they experience. For example, a Black woman's experience with implicit bias may be more intense than that of a Black man or that of a white woman, because judgment is made both on one's race and one's gender. In the healthcare setting, this might look something like being dismissed about your pain because women are dramatic, and being Black means you are less willing to follow through on a treatment plan. Where a Black man with the same symptoms might be overprescribed pain medication by the same doctor, and a white woman might have tests ordered to determine the cause of her pain. Next slide, please. So how did we get here? In the past, physicians used overgeneralizations and stereotyping based on one's race, ethnicity, gender, or other features, as it helped them narrow down potential diagnoses and circumstances where disease was more prevalent in a certain population. While African Americans make up 13% of the US population, they only represent 6% of physicians and 3% of medical school faculty in the US. This is important as studies show that the quality of medical interactions between Black patients and non-Black doctors suffers due to implicit bias. They show non-Black doctors tend to spend less time and are less patient-centered and speak faster, resulting in a less positive effect. It is estimated that 80% of medical interactions for Blacks in the US are with non-Black providers. If there were more Black doctors in the workforce, Black patients would have a better chance of seeing a Black doctor and therefore have a more positive medical interaction. The low representation in medical school faculty could also have a negative effect on the admission process for Black candidates, making change in this metric more difficult. And as I'm sure most of you are aware, there's a cultural mistrust due to past wrongdoings. The experimentation by the government on Black men with syphilis in the 1930s and 40s has had a lasting effects on the Black community and created a culture of mistrust that has affected generations of Black families. Next slide, please. So why are these important? Why are biases in healthcare an issue? As we look at this iceberg model, the obstacle we see is only the top of the iceberg. In this particular model, that would be these disparities that we see in births and maternal health. But in order to address the obstacle, we must remember that most of the iceberg is unseen, and in order to adequately handle the obstacle, we must acknowledge these other pieces that go into it. So as you see here, economic stability, medical baggage, racism, limited access to healthcare, those are all things that we just discussed when we were talking about implicit bias. Next slide, please. Implicit bias in healthcare. So you can have implicit bias in both the provider as well as patients. Stereotyping someone based on their gender or race becomes problematic as providers can be blinded by the anticipated diagnosis and fail to look beyond it, which can result in misdiagnosis of the patient, or in some instances prevents a diagnosis in another patient because they don't fit the stereotype. Studies show that treatment decisions can be indirectly influenced by biases due to assumptions by physicians about patient behaviors, aftercare, and risk levels. This can cause the physician to be hesitant in offering appropriate treatment and delaying care for patients. One study showed that physicians were less likely to recommend PrEP treatment for Black men with HIV exposure than white men because they perceived Black men would take more risk than white men if they were given treatment. In addition, patients can take their own biases with them when seeking care. This can be based upon their own previous experience, both within and outside the medical context, or someone in their circle's experience. In addition, it's been shown that even the potential to be discriminated against for Black patients is enough to influence their reaction to medical care and healthcare professionals. The historical mistrust, as mentioned earlier, may also lead people to delay seeking care or services or be less receptive to the information or guidance that is given. Many of the studies conducted around biases in healthcare take into account physician-patient interactions and are not necessarily all aspects of the healthcare setting, which include other licensed and professional staff who may interact with a patient and their biases. So all of these together can lead to misdiagnosis, delays in care and services, or lower quality of care from the healthcare provider. And that's not just the physician that one may see, but from the office staff as well. And it can lead to patients delaying care and seeking services themselves, and just have a general mistrust of the information that's being provided to them. With that, I'm going to turn it over to Anna.
Thank you, Amy. So you might be wondering, so what does any of this have to do with ACEs? We're at an ACEs conference. Well, this is what it has to do. So Amy showed you a model of the iceberg, and this is the ACEs equivalent, right? I refer to it as the tree model because obviously there's a tree on here. But again, it does the same thing as the iceberg model. You're looking above and you're seeing the things that you might be able to really tell in real time. If I'm looking at you, I might be able to tell that you're homeless. I might be able to tell that maybe you have some mental health issues. If I know you, I might find out that you went through a divorce. But all those underlying what they call the community, adverse community effects are the things that are sitting under the iceberg. Okay. And again, in the Black community, they're going to have significant impact. So let's start talking about what those look like. Maternal stress is a key factor in the high Black infant mortality rate. For time purposes, we're just going to walk through kind of the top three that are known through research at this point. Those are cortisol, microaggressions, and systemic racism. So for those of you that don't know what cortisol is, it is the stress hormone. So for the average person, if you get stressed, your cortisol kicks in and it brings you down a level. In the average African-American, their cortisol kind of doesn't work. So when they get here, they stay here. And when you stay here and you get more stress in your body, you only get higher and you kind of get locked in position. You never get to go back down to square one. That's huge because they've known in research that this can cause high blood pressure, issues with insulin release, all things that are going to be detrimental to a pregnant mom. So how does it affect Black moms? Let's start with the basics. Stress is based in fear. In the Black community, you often hear people say we live in fear. So imagine everything that you do, every choice that you make is based in fear. Decisions are made based in fear. So again, that cortisol isn't going to work because if I'm afraid all the time, then I can't decompress. I can't come down. Again, this leads to chronic health diseases that can affect before, during, and after the pregnancy of a child. And we know that when mothers are super stressed during pregnancy, it is affecting the fetus. Again, can create a situation where infant mortality is real. So let's talk about racial microaggressions. Most people understand the idea of racial and what that means, but may not be very clear around what microaggressions are. So microaggressions are typically when something is said where someone may feel like they're not being offensive, but to the other party, it was 100% offensive. Let me give you some examples that happened to me personally. I'm often told that I speak well. Compared to what? Compared to who? Are you implying that the average Black person speaks a certain way, and because I speak a different way, I talk well? Or I have good hair? I'm often not only told that I'm good hair, but then people take it upon themselves to want to touch it. It is not an open invitation. You wouldn't necessarily touch someone else's hair, but something in them believes that it's okay and acceptable to touch my hair because I wouldn't be offended because I've been given a compliment. You heard Ms. Sharon speaking earlier about my education. I'm a fairly highly educated Black woman. But any time there have been times that I have talked to somebody, they found out that I have an education because it's not something I broadcast. And then they asked me, what sport did I play? I'm sorry? Well, what sport did you play in college? Implying that the only way I could have gotten an education as a Black woman was because I played a sport, and that's how I was able to get an education, not because I actually had some intelligence behind me. Let's give a medical example. So I have my own health issues, as most Black women do, and I ended up having a high-risk pregnancy. So I had to see a very particular doctor. And upon entering my first appointment, I was met with, how did you get an appointment here? I thought the question was like, oh, how did you get an appointment here, right? No, the question then followed with, we don't take Medi-Cal. I never said I had Medi-Cal, nor did I ever say that because I'm a Black woman, I would have Medi-Cal. Those are racial microaggressions. They're not always said with negative intent or hurtful intent, but that little underlying implicit bias comes through in a verbal state called a microaggression. Okay. So what does that do to the Black mothers that we're talking about today? It really becomes a head game. It can cause depression. It can cause frustration. It causes people to be isolated. And it's a real mental health game. So let's talk about mental health. There is a huge stigma in the Black community that mental health is a negative thing. So if I'm unable to go see a counselor, join a group, be in therapy of any kind because I'm following this stigma, because my fear, again, my fear leads me to believe that if I were to do this, the outside world would see me as less than, and I'm already climbing that ladder every day. So I don't seek treatment. But if I can't figure out how to have coping mechanisms and have a way to bring myself down, I'm only going to exacerbate the health issues that I have. Because if you've ever been depressed and if you've ever felt isolated, you're probably not going to the doctor, and you're probably not seeking help, and you may not even be talking to your friends. Again, causing detrimental lifestyle to the women, the Black women, any woman really. But in this case, particularly the Black women that are pregnant, that are trying to have a joyous and healthy, happy birth. The next topic is systemic racism. Most people, we're going to assume on this call, are aware of the term of racism, and I'm not going to go through what the definition that is, but this is a very specific type of racism. This is about a systems change issue. This means that there hasn't been the ability to change a system treatment of Black women, Black persons. Okay. It either means that they've been set up to no longer be able to receive access, period, or they're given so many additional hoops that either people give up or they just, it's not worth it. And that becomes a serious, serious problem, especially in the healthcare community. So the key word I want you to take away from here is system. Keep that in mind. So again, how is this impacting the Black mother? I don't need to keep repeating myself. It's a mental game. It's a physical game. And what ends up happening is severe consequences, long-term consequences by others' actions. And in this case, due to systemic racism. So I'm going to pull up a poll right now. In this poll, kind of asks you the question, what is systemic racism? Unlike Amy, I can see when you guys are answering. Give a couple more seconds. I love that everybody cheated off of each other. It's fantastic. So everybody answered all of the above, and everybody would be absolutely correct. But in case you just assumed the answer was all of the above, let me kind of walk you through how this works. So political disempowerment, let me give you an example. Let's start with the basic one, round one, our Constitution. It says that Black men counted as 3/5 of a person, not a vote, a person. And that system continued. All rights were given to voting in 1870, and yet for the next 100 years through the Jim Crow laws, Black people were absolutely not allowed to vote. And the ones that figured out that they did have a right to vote were met at the door with violence, aggression, so that they then, again, not worth the battle, would turn away. In 2021, we still have states that have legalized gerrymandering as part of their voting counting. And if you don't know what gerrymandering is, let me explain. Gerrymandering is when you can say that a vote doesn't count for 100%. So there are states in the United States of America from the last voting cycle in 2021 that still have that votes of different people of color do not count as a whole vote. Maybe it's 75% of a vote, maybe it's 50% of a vote, but either way, they are not officially being counted holistically. This is a systems issue. Okay. Segregation. I'm not going to talk about segregation. That's the thing, that's the one thing you learn in high school, right? You learned about the white colored this and the black colored that, your drinking fountains, that you lived across the railroad track. So we don't need to spend a lot of time on that. But I do want to talk a little bit about environmental injustice because it's not something that's that common. Environmental injustice is sneaky because a lot of people don't see it and they haven't put the pieces together to realize that this is a systems issue. If you are a coal burning factory or you are a waste management hazardous waste disposal unit, have you ever paid attention to where they locate those factories? 9 times out of 10, and let me just say it's more like 10 times out of 10, they are in a people of color, low income community, implying that their health doesn't matter enough for them to be given the same safe air, water that maybe another race would be allowed to have. This is a systems issue. They're not spreading the wealth. They are making a calculated decision on where they're going to place these harmful companies, organizations, factories, depending on where you are. Again, impacting, severely impacting Black mothers, Black people, people of color. So now that I've completed, stressed everybody out here, let's talk about what's really going on. So the Department of Public Health, represented here by the Assistant Director, Amy Rutledge, and myself representing First 5 Kern, have joined forces to really address here in Kern County what that's going to look like. But before I get into that, let me talk about what we're doing at the state level. So I am First 5 Kern's representative on the state level. The state over the last 3 years has delineated that this is something that really needs to look at. You saw the stats for California, they're extremely high. It shouldn't be okay to just allow babies to die. It shouldn't be okay to allow their mothers to die a year afterwards because they had complications and no one paid attention. So the California Center for Policy is through the First 5 Kern Association. For those of you that are unfamiliar with First 5, we are a funding agency on the state level, and we fund programs for pregnant women and children ages 0 to 5. What they're doing at the state level is they are looking to do some research in conjunction with the University of Berkeley, and they've called it the California Preterm Birth Initiative. This initiative will be implemented statewide, and it's going to be doing not only the things you see listed here on the bullets, but it really has 2 major outcomes that they're looking for. Okay. The first is a long-term project, which I'm going to talk about in the next slide. And the second is to create a local assessment tool so that counties throughout the state of California can really assess what are they doing to address Black maternal and infant health. And they're doing it under 4 pillars. The first pillar is community networks and partnerships, which, as I'll talk about in a moment, Kern County, we're ahead of schedule. Pillar number 2, representation and support of Black women. Pillar number 3, equity and effectiveness. It's not enough for you just to create an equitable situation. You have to take it to the next step and make sure that it's effective. My words don't matter if my actions don't match. And pillar number 4, accountability. I can say all the right things in the world, but if no one's holding me accountable to it, does it really matter? And does it really exist in real time? The answer is no. So let's spend a minute and talk about what this preterm birth initiative is really looking at. So their baseline data is that more than 1/3 of infant deaths are related to being born too soon. You see 4 categories here, but there's really 5, so let me explain. They're going to be looking at the birth of the child, okay? That is that first year that you heard Amy talking about in those slides. We're going to follow these families in this first birth year, the birth experience from as early as conception as they can get a hold of the mom till the child's first birthday. And they're going to continue to follow that child through their whole first year, okay, the first year of life. Then they're going to look at their childhood, and their childhood is thinking like a toddler to when they at least graduate 6th, 7th grade, okay? The initial hope is to get them all the way through high school, but we live in California and it's really expensive to live here, so they're not sure how long that trajectory will happen. But the goal is to have them through high school. And then adulthood is really going to be done on 2 parts. So adulthood is going to be that child all the way through adulthood, if we can follow them through there, right? Whether they go to a great trade school, whether they just get married and start working, whether they decide to go to college, whatever that path is that they have, we're going to follow them because we want to see whether or not there were anything that happened early in life that's created these chronic issues later in life. And what does that tell you, people? That's ACEs. That's what ACEs is all about. Things that affected you in childhood manifest themselves and show themselves in adulthood. So being proactive in a childhood will help families be able to have a healthier, longer, and sustainable life in adulthood. And the other part of adulthood is not just the child's adulthood, but through this whole scope of these 4 squares that you see on this slide, we're going to be talking to that mother and her adult journey, right? We don't want to forget that just because she had birth doesn't mean that she could still have some health issues and some traumas and things go on in her life. We're going to be looking for trends. We're going to be looking for things that we can pinpoint so that we can go back and say, we could do something about that. So with that being said, you're probably like, that sounds great, Anna, but that's in California. So what are we doing in Kern? I'm glad you asked. So we have created here at Kern County, for the first time, let me notate, and for those of you that have been partners in this, give yourselves a round of applause, pull up the emoji happiness, because you absolutely deserve it. The local efforts are this. Starting February of 2021, there was an initial group that met together that said, hey, this is an issue and we need to address it. I personally have waited for this for 8 years that I've been learning about these stats and why we're not doing anything. And the new director of public health said, absolutely, what do we need to do? How do we do it? Let's start something. Tell me what we need to do. And together we created this initial group of people. And those people said, hey, I work with these people and they should be at the table too. So by July of 2021, we created this system where we brought healthcare professionals and organizations with community-based professionals and organizations, probably for the first time in Kern County's history, to the table together to say, this has to be a collaborative effort. And most importantly, we need to hear the stories from the people that it's affected by. And we were blessed to have Black mothers of every age, of every socioeconomic type, come to the table and say, this is my story, this is my experience. So almost a year later, believe it or not, we have created goals that will go to the Board of Supervisors in June of 2022, in just 2 months. They have met every single month. Each month had a task. More than 30 organizations throughout Kern County have been represented in the steering committee. They created the goals, they created the objectives. Just a couple weeks ago, they have finalized the document to move forward to the Board of Supervisors. Let me explain and pause so you understand how significant this is. By now, in hearing the stats, you guys probably understand that this is a big deal and we should probably be doing something about it. We will only be the 4th county of 58 counties in the state of California who is known for being super kumbaya and hug a tree. This is going to be the 4th county in the state of California to mandate and make part of a strategic public health initiative that Black lives matter, that Black mothers' health matter, and they're putting in writing. And that accountability piece that we talked about earlier is going to hold. I affectionately call it BIMHI because I live for an acronym. But if you start hearing about the Black Infant and Maternal Health Initiative, that's what it's all about. And let me kind of go over what some of these goals will be. So the goals are to engage more African American healthcare professionals. And let me explain why that's really critical. Statistics have shown and demonstrated that if you work with someone that you feel has a like history, sense of place, purpose as you, if you see yourself in someone, you're more likely to be more open, you're more likely to share, you're more likely to feel like there's a connection, and relationship building is key in any time you have a healthcare situation, regardless of color. But because we have so few and so limited people of African American descent in the healthcare profession, the team, the steering committee decided that this was critical. This needed to be a goal, that we needed to see more Black faces to provide that additional care to the people in the community. The second one is to address mental health as a factor in African and infant and maternal mortality. I'm not going to get into it because we talked about it earlier. Looking at the 3 factors, 2 out of the 3 explicitly said it was a mental health game. And after I told you that the Black community doesn't go and reach out for mental health, we've got to break that stigma. How do we do that? We do that by bringing in the people that look like them. We bring it in by having groups of people that look like you, right? Maybe the facilitator doesn't look like me, but everybody else in the room does. And so when we start sharing experiences, I may be open to get more help than I would be before, et cetera, et cetera. And the third goal that was determined by the steering committee was to increase provider awareness of African American infant and maternal health, which essentially is what Amy and I are here doing today. The difference is we're going to be targeting not just the community at large, which obviously we want to do, but provider specific, meaning that Dr. John that works on our street is going to have the same information as everybody at Mercy Memorial Hospital, Dignity Health. Sorry, I'm old, right? And why is that important? That's really important in Kern County because we have a very, very transient, traveling healthcare system. We have traveling nurses. A lot of our doctors, Valley Children's, those doctors don't live in Kern County. They come to the county for a week. Maybe they're here for a month, or maybe they come every Wednesday. But if I'm just visiting, then I don't truly understand the issues that evolve around Kern County. And it doesn't mean that I don't want to know. It just means I assume something because that's human nature. We're going to take the human nature out of them and we're going to give them an educational opportunity. Because when they realize that this is what we're really trying to do and that these are really the numbers that are happening in Kern County, our hope, our prayer is that they take it seriously and they say, what else can I do? So this is our ask out of today. Would you be willing to represent your organization in participating in the goals that we are going to be using moving forward? Are you willing to educate your community? I know there's people on this call right now. Kern County is 8,000 square miles. It is not a small little piece of land. And I know there's people that are all over the county on this call right now. Are you able to sponsor efforts? That doesn't mean you have to write a check. It means maybe you have a place where a meeting could be held, or maybe you could do some in-kind services when we need some volunteers. This is going to take the whole community to make this work. 8,000 square miles is a lot of people to cover and a lot of people to be educated. And if you don't think that's a good fit for you, that's okay, we understand. But would you be willing to recommend an organization or a person that you feel would be a better fit? So with that, I'm gonna ask you if you'd be interested in helping at all. And it's okay to say no. Give a few more seconds.
Anastasia, I didn't participate in the polling because I don't even know if my agency is interested in doing that.
Okay, that's fine. And we'll give you our information and you can let us know at a later time if that works for you.
Yes, but I would like to add that what I can see in the families that are part of my caseload, that they live in isolated cities. You know, healthcare services are far away, and some of them, they don't have transportation. It is a challenging for them, and some of them, they need to go to LA County because they get appointments more easily in there. It's kind of difficult to the families that I serve.
Great. Can you
Mhm.
contact me and we can have this conversation?
Okay.
Perfect. And she just segued me so I didn't have to say anything else. So two things. If you were a person that said yes, we're going to pull up our information right now. And there it is. And you can email us directly and say, hey, can I help? What do you need me to do? Or if you're like, I don't have time to do that, you contact me. Feel free to put your information in the chat and we'll reach out to you. Again, we're hoping and feeling strongly that in June, these goals are going to be approved. And then July, you're going to hear it kind of everywhere because the 3-year goals will be in full swing and full motion. So with that, Ms. Sharon, are there any other questions that you see from the chat, or we can open it up to others?
Sorry about that. Nothing in the chat. Go ahead, take it away.
So I'll open it to the floor. Is there any questions from anyone in the audience? Feel free to ask. Yes, Ms. Pickney.
Good afternoon, everyone. Thank you for bringing this information to us. I really appreciate it. So I was listening earlier and I heard that you, Anastasia, you had an opportunity to sit around the table at the state level and discuss Black maternal and infant health. So my understanding, and I'm in Merced County, First 5, and we are located inside of public health, is that they have programs in each one of the counties for this, but the criteria is to have the African-American population in your county above 5%. And so unfortunately, my county has African-American population of 3.6. And so what is the conversation for counties that fall underneath that 5% threshold? Because, and I'm sharing this because as an African-American woman, I've also had, an educated African-American woman, I've also had issues with doctors from other countries that have stereotyped me without even looking at their own chart. and just be like, you must have diabetes because you're African-American and you're larger than what a non-Black woman would be. And I'm like, no, check it, check in your file. I took the test. I did the whole blood sugar test, like look in your file. I don't have gestational diabetes. Oh, you're gonna have a big baby. We're gonna have to schedule that for a C-section. My last baby was 9/15, check it. I don't need to. So those types of things happen. I've had family members who have had these things happen to them, but because we have such a low African-American population, it's like we do not have those programs here. We don't even, I don't think we even have funding for that here. Is there something that we're doing, they're talking about doing regionally, where numbers are incorporated and we can get that type of assistance on a regional level? Just really interested because that is one of the areas where we struggle in as well.
So I'm going to answer this 2 ways, and then I'm going to allow Amy to answer it from a public health perspective. But from a First 5 perspective, legislation states that any and all families, regardless of percentage of a population, can and must receive services. So that's something you're going to want to bring up with your director, because the reality of it is, if that population, regardless of the size, if it was 0.5, our legislation from Proposition 10 states that we are supposed to be providing services to all families, regardless of race, creed, color, sexual orientation, or identity. So that means if their population is not being addressed in one way or another, there is an opportunity to provide funding one way or another, whether that's drawing down funds from the state so that you can have expansive services in maybe like a prenatal program that public health already has, but you designate dollars from First 5 to address just the Black population. Contact me offline. We can have some more dialogue around what the state is working on. You're part of the Central Valley family. Hugs. So when we start working Central Valley regional stuff, I will definitely make sure that you are included in those conversations. Amy, do you have anything to add?
I think I would just say from a public health perspective, looking at what your rates are overall, in comparison to the state. So we're only 6% here in Kern County, so not, abundantly large either in comparison to the state. But I think looking at what your percentages are and how maternal and infant health is prioritized in the county as a whole, and maybe just starting from that perspective, if it's not already part of the plan, and expanding that, as Anna said, kind of into those more specialized services, specifically focusing on the Black population, because overall, I think, you know, as a state, we're certainly higher significantly than even nationally. So just looking at it from those kind of micro perspectives, even if it's not, you know, the population is not large in comparison to the county, what do your deaths look like for that small population? You might find it just as surprising in terms of the data.
That's basically because I've had these conversations with our director of nursing in public health, and then we have a new division manager for the nursing department. And looking at the data is the next step for us, just so that we could advocate for those that are experiencing any type of negative impacts from maternal child health, or in the area of maternal child health. And so, but those are the questions that have come up for us, because, you know, that's the pushback. Oh yeah, there's only 3.6% African-American population here in this county. So at the state level, we're under 5%. We're not seen like that. And so we definitely can, I have a very good executive director. And so he's open and receptive to those things. It's about looking at the data. But my thought is that if we're doing this on a regional level, that we could at least participate, be around the table, so that we could be the fly on the wall to hear ideas and glean from them, most definitely, and just see what we can do, make little inroads here and there in the meantime.
Yeah, be sure and contact me and we can have that conversation.
No problem. Thank you.
Yes, Mr. Gutierrez.
Great presentation, Amy and Anastasia. You know, I know you talked about a little bit about the plan and recommendations going to the board in the summer. You know, what kind of advocacy or engagement can folks on this call participate in as this moves forward, you know, and gets adopted by the county? Can you speak a little about that?
Amy, did you want to start?
Yeah, so I would say the goals, Anna gave a quick overview of what our goals are. Our objectives are really focused. We have a lot that we are planning to do really in that first year. A lot around campaigns. So we do plan on doing a really big push to get the data out there, to get the information out to the community as a whole, and to build upon that for our partnerships. So I think staying engaged and knowing that it's going to be coming, and when it comes, it's probably going to be pretty fast and furious. At least that's our goal. And once they have that information, knowing how they can use it in their, you know, particular setting, and what would be needed from us in order to help populate that, or if they hear the information and they know, I definitely can help with the mental health piece, or we can help make contact with professional organizations that need this information. Those are the pieces that we have some of those pieces in place, but we will always take more of those pieces. So if you have any of those, certainly email Anna or myself or both of us, and we'll see where you fit into that. And we'd be happy to get you more information on that. I don't know if you want to add anything else to that, Anna.
No, that's exactly what I was going to say. Just so you know, there's 9 objectives to support those 3 goals. One of the goals is literally due in a year. It'll be due in 2023. So those first 3 objectives are going to be kind of the real target focus. So again, if you just have an interest in finding out more, we didn't want to go through the objectives because, again, we didn't want to put a whole bunch of stuff on the plate and then find out that there might be a revision or there may be additional questions from the Board of Supervisors. We're hoping not, but just to be very transparent, we knew that the body of the goals were going to be solidified. There may be some modifications to what they are looking at in the objectives, and so we may have to revisit that with the steering committee. That's kind of going to be based on what the Board of Supervisors want, but anybody who wants to be involved, to just let us know. We have a BIM high blast is what I affectionately call it. and Amy is superior at making sure that anything that comes down the pike around Black maternal and infant health, she makes sure that everybody has it so that everyone's talking the same language and everyone is up to date on the most current information that's either coming from the state or here locally. Does that answer your question, Mr. Gutierrez?
Yes, thank you so much.
Thank you. Any other questions? We've got about 2 minutes before I turn it back over to Ms. Sharon. If there's one more question, I'll take it. Otherwise, I'll turn it over to you, Sharon. Going once. Going. We must have been amazing,
Thank
Amy.
you.
We must have been amazing. All right, back to you, Ms.
Thank
Sharon.
you, Miss Lester, and thank you, Miss Rutledge. We do appreciate you. Wrong pair of glasses on, ladies. Give me just a second here. Okay, so before I let you, for everyone go, I just wanted to let you know that if you have any questions and they weren't answered, they will be placed and answered in the Hoover app within the next 2 weeks. First Five Kern will be developing a question and answer document to address any unanswered questions. They will be located in the community tab of the Hoover app. Also, once you leave here, don't forget to join the afternoon plenary session, Strategies to Advance Health, Justice, and Healing for Communities in the Central Valley and California, beginning at 3 p.m. To get there, leave the session and click on the link in your Hoover app or on your computer. We hope you have enjoyed this workshop and have appreciated you being here. Have a great rest of the conference. Goodbye, everybody.
Bye, everyone.
Claire, absolutely. Give me a call. I have no problem addressing that question for you. And we can work together to see what we can do to help with your request. Not a problem.
Okay, wonderful. Can you hear me right now?
Yes, ma'am, I can.
Probably no one else is involved anymore. I work for the Bakersfield Pregnancy Center, and I guess I'm just telling you now. Maybe I should do it offline. Anyway, I'm a nurse sonographer, and we just really would like to be reaching more of the Black community. And I know I'm making mistakes. I know we are making mistakes in our outreach and our search engine optimization. And I just want to know how to do it better. I am white, but I have a very strong desire to help people of color. I learned Spanish specifically to help with my Hispanic clients. I'm very motivated. But anyway.
Well, we're working with Erin right now. So if you want to get together with Erin and we can sit down, I can sit down with you. Miss Ameta, I'm sure would be more than happy to join us in that call. That's why I left her on this call. And I didn't kick her out like I kicked everybody else out. So just let us know, like sit with Erin and find out like what times work best for you. Send me an email. Miss Ameta and I can set up a time and we can kind of talk about what you guys think the barriers are. Maybe you don't have as many barriers as you think you do. It could just be an engagement issue and we can really talk about it, really hash it out.
Okay. I think, yeah, Erin is wonderful. I think I'm just looking for a more boots on the ground. And I definitely don't want to exclude her, but maybe it would be better to engage with our nurse manager.
Okay.
So, because we have a very close relationship with Erin and we love working with her. She's probably not as detail oriented. She's more of a visionary. So yeah, that anyway. Problem. Okay, great. I will email you.
Perfect. Please do.
Thank you.
Thank you. Thanks for coming.
Bye-bye.
Bye. And Meta, are you still there?